Good afternoon, all. Welcome back to our foundation course in palliative nursing. Today, we are going to have our second session, that is on introduction to pain. We have Dr. Radha Venkatesan as our faculty today and Sister Sheba as our facilitator. I'm welcoming Sheba ma'am for a brief introduction of our faculty. Please, ma'am.
Thank you. So, good afternoon to all. Happy to see you again. Today, we are going to learn about introduction to pain. So, that will be taken by Dr. Radha Venkatesan. She's a anesthetic. Basically, she is an anesthetist. She has worked in abroad more than 5 years, and she has worked in Adair, Kansas Center as a palliative care physician. And also, she has an experience in chronic pain management. Now she back to UK, also working as a pain physician there. Madam, welcome and over to you.
Thank you very much. Thank you to Pallium and Tips. It's a great opportunity to be with all of you and share our experiences. So basically to help each other so that we render the best possible care to the patients whom we see. Okay, so is it okay to start the presentation straight away?
Yes, ma'am.
Just a minute. Can you see my screen?
Yes, ma'am.
Okay, thank you very much. Okay, good afternoon to one and all. It's a pleasure. Together in the next like 30 to 40 minutes, we will see and learn about pain to the best possible extent. As I mentioned, see, we are learning this mainly to render best service to the patient. So if we know, then we can do the best. So that is the main aim and goal, what we're going to try to do. Okay, the International Association for Study of Pain had initially given a definition in 1979, which was in practice. But recently, in July 2020, they've just revised the definition after having a big consideration with a big team for about 2 years. They've come with a refined definition, adding some few factors, which they mentioned as adding 6 keynotes. Okay, what is the actual definition? Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And it is also expanded upon by the addition of the 6 keynotes, which they have mentioned, along with the etymology of the word pain. Here, we have to give importance to each and every word in the definition, because understanding that will make us understand pain better. If we understand pain well, we can do the best. So it's a sensory, emotional experience, and also see the words. It could be an actual damage or a potential tissue damage. Everything matters. Okay. And the main 6 factors, what they've added are, we will see that next. Pain is a personal experience. What one person experiences cannot be expressed by the other person. So that is why here they mentioned it's a personal experience, because it can have biological elements, social elements, psychological element. So all those have to be given sufficient weightage. Next comes, we have to know to differentiate between pain and nociception. So now we have seen definition of pain, which says that it has got so many multiple components in it. Next, what is nociception? Nociception actually is a process of recognition of various noxious stimulus. It could be touch, temperature, pain, heat, so many things. So just the process of recognizing the stimulus is nociception. And pain, we have seen it has got multiple components. So this difference between nociception and pain has to be clearly understood. Next comes, patient's expression of pain is to be respected. We just can't say, oh, no, that is not thing, you're thinking something. It shouldn't be not given importance or anything. We have to respect what the patient says and then see, oh, is that true? How much is true? So we have to look into it. So that is of importance. Main again here is it is a subjective phenomenon. What the patient experiences, the other person cannot experience. That is why this factor, the expression to be respected, is mentioned there. Next comes life experiences do have a role. For example, at the time of injury or along the period, they might have had some bad experiences or something, which will have a role. So we have to see how that can be changed. We know like some things may be hard inculcated into them, but still we should try to see, okay, they've had an experience. How can it be modified? So that also needs to be considered. And next comes, usually we from like basic studying medicine or nursing or whatever you do, when you study the physiology and things, we have learned that pain is usually a symptom. It's a helpful thing because pain is there. We are able to find out what the problem is. But it is usually a symptom, but it can be a problem or a disease also. How and why it happens, we will see during the course of information that we will see in the further slides today. Last, verbal expression is not the only mode of expressing pain. Why it's mentioned like that? See, sometimes a person may not be able to speak, but still pain can be expressed. An example would be, see, sometimes like a grimace or a sad feeling, or like increase in heart rate, blood pressure, that also are also signs of expression of pain. So it's not that someone has to tell I have pain. We can find out. Here we know that pain is considered as the fifth vital sign. So we, being in our profession, we know other ways of expressing also. So that also has to be borne in mind when you think. So why have they added these factors? There is significance. That is why they've added these factors. Just one thing there, I just want to make sure I'm not too fast. Hope I am in the right pace for all of you to understand and express. Shiba, is that okay, or do you want me to go a little bit slowly?
This is okay, ma'am.
Fine. And that's why, see, I am trying to go in a pace which will be comfortable for all of them. So that's why. Thank you very much. Dear.
Okay, ma'am. Thank you.
Okay. Next thing comes is like very basic understanding of what is physiology and what is a pain pathway. That is why I've given a diagrammatic representation here so that pictures convey more things than words. So with this itself, we'll have a quick overview and then go into other factors. So here we have got the nociceptive information, which could be like, it could be a touch from the skin. If it is a joint, it could be a stretch. Or if it is like a viscera, it could be a distension of the viscera. So various types of nociceptive information from various places can arise. What happens next? When the stimulus is there, you also have some release of mediators, which if you see in this picture, you have various mediators mentioned there. And then you have those information, chemical. See, always in our body, we have many chemical, electrical connections. See, electrical means it's not physically electrical. How? By the chemical substances in the body, these information are all carried. So from the site of the nociception, you have chemical mediators released, which form a big, it's said as an inflammatory or a chemical soup like creation is made. Those information are carried by the ascending pathways, like the nerve fibers. You have different type of nerve fibers, small fibers, big fibers, like that, C fibers, A fibers. And then they go to the spinal cord. In the spinal cord, you have the dorsal column where some interaction and connections take place. Then always with pain, it passes on to the opposite side. And then you have the ascending pathway. Then it goes to the brain where in the thalamus and things, brain pain sensation is perceived. And then it is brought down by the descending pathway. And then comes back to the site. And then we say, oh, I have pain here. Okay. So all this ascending, descending, they have significance. in one thing is to perceive pain, and the same thing, why this importance of understanding physiology is there? Because if we understand physiology, based on the physiology only, treatment also is going to happen. Sometimes we'll see how we can change factors in the dorsal horn, or sometimes in this descending pathway also has a inhibitory effect. So what happens is that is used. For example, when someone falls, we rub on the site, oh, then the pain reduces. That happens because of this descending pathway having an inhibitory effect. By just having touched there, the big fibers are stimulated, which reduce the pain. So the understanding this pathway is important because it helps us in understanding how we perceive pain, and also to understand how we can manage and reduce the pain. So that is why this is important. Next, significance. Why do we need to know all this? Because pain is a multidimensional and complex phenomenon that requires comprehensive ongoing assessment and effective management. So it is not one time. We will see through our slides that we have how we are going to assess and manage also. Hence, good knowledge is very essential. Next comes the pathophysiology. Why is this so complex? Everything we are going to reduce it and find out why and how, so we will be able to understand. The mechanism by which a stimulus in the body is perceived as pain by the brain is a complex one. The complexity of the process results because the nervous system not being a hardwired system, but exhibiting plasticity that enables it to modify its function under different conditions. I will explain a little bit more about this. What is a hardwired system? What is plasticity? Hardwired system is like you have one stimulus, one response only. That is hardwired. Whereas plasticity means one stimulus may be there. One time it will respond in one way. Next time it will respond in another way. Because why? Because the human central nervous system has multiple components. It has sensory, motor, emotional, functional, social, everything. See, for example, who you are, and then you have, we develop certain factors. I have to behave like this. I have to behave like this in this environment. I have to behave like this in another environment. All these are perceived in the brain only. So that's why it's not a hardwired system. It has the capacity to have all factors. So that is a positive one, but that itself can become a negative one if the pain or the system starts to behave differently, which we will see in the varied mechanisms which happen and make it like that. Okay, that is the significance why this has to be understood. Next, pain serves the purpose to prevent tissue damage and protect the body, which we saw previously. That is how we normally think. But under certain condition, pain can become maladaptive and persist as chronic pain. That is why, see, for in neuropathies and things we see, why, which is a good thing, is becoming a bad or a difficult thing to manage. Hence, when pain serves no protective function, but becomes pathological, it is a disease on its own. That is why this chronic pain entity itself happens. Okay, now we will briefly see what are the pain modulation mechanisms which happen in our system. Broadly, we can divide them into peripheral sensitization and central sensitization. What is peripheral sensitization? We saw that nociception. So in the periphery, or where the site of injury of the pain is, we saw there is some chemical mediator release. What happens? Initially, these cytokines, prostaglandins, all those are released. What they form, it is called as an inflammatory soup, because multiple chemical mediators are released. And not only that, at the site of injury, it doesn't stay just at the site of injury. Sometimes just that site of injury triggers the surrounding structures also to release some chemical mediators. how it acts by spontaneous or ectopic discharge. Normally, there should not be discharge, but some extra sensory fibers get stimulated. So small area of injury can become a little bit bigger area of injury. And another factor is it will modify it has the ability to modify the response also. Small response can become big. This is known as peripheral sensitization. So at the site of injury, along the site of injury, so a small, for example, it was a 1 centimeter site of injury, but it can spread and become a 2-3 centimeter. That is why, for example, if someone has an injury or a fracture, has some surgery, and then what happens after even 6 months, 1 year later also, they may have pain in and around. The site was a small one, but they may have, oh, my whole arm hurts. So that is because of this peripheral sensitization. So that is one example. Okay, next comes central sensitization. Central sensitization, as I explained previously, this neuroplastic change in the central nervous system, the plasticity, it can change. It is capable of changing because of various factors. So that is one phenomenon. And next one is called as wind-up mechanism. What is wind-up mechanism? This is something important which we need to understand. Basically, for example, one stimulus produces 5% response. Whereas if there is wind-up response, what happens is it is amplified. We know what is amplification. We have heard amplification is making something small to something big. So that is one of the reasons why a small size of pain can become a big one. So this wind-up mechanism is one of the important mechanisms in causing neuropathic pain. We will see what is neuropathic pain in due course. So these two, this wind-up neuroplastic changes can be short-lived or long-lived. So generally it is said that wind-up is short-lived, whereas if it becomes a central sensitization, it can become a long-lasting phenomenon. So this central sensitization is one of the important underlying mechanism for chronic neuropathic pain. See, this chronic neuropathic pain is basically pain having nerve elements in it, which we will see. We will describe and see the various types of pain. In that time, I will explain a little bit more in detail. Next comes the types of pain. We have seen so much of information about the physiology, pathophysiology. So that is why we have, when so many elements are there, so many types of pain are also going to be there. Okay, first what we will see is acute pain. Pain that is present at the site of injury, mediated by nociceptors. For this, we can give example of like heat, touch, pressure, anything. If someone has a fall, injury, all that will be acute pain, which is there at the time. Next comes chronic pain. Chronic pain is pain related to pain in conditions such as diabetes, mellitus, arthritis, tumor growths. So in acute pain and chronic pain, you can give also a time frame. Acute pain is only short-lived, few days, few weeks. Chronic pain is something which is lasting for more than 2-3 months. See, for example, as we've seen, diabetic patients do have a pain in the extremities. Peripheral neuropathy is a common thing. Arthritis. See, arthritis is not pain only for short time. For years together, people have pain. They have one episode, some infective inflammatory arthritis, one episode, few weeks. But lifelong, the pain lasts. So you can give time factor, nature, everything, both differences can be said for the acute and chronic pain. Next comes somatic pain. The pain that is generated by nociceptors in deep tissues, like tendons, muscle inside. So those type of pain will be somatic pain. Next comes visceral pain. Visceral pain is pain which is felt in deep viscera, like the gastrointestinal pain. That is mainly due to the stretch, what they say is distension of the viscera and things like that. That example would be for visceral pain. Next comes the important factor of neuropathic pain, which is caused by the damage to the nerves resulting in increased firing. So here, I will just try to explain a little bit more. See, actual nerve damage per se, when they have some big crush injury or incisional injury, those type of thing, the nerve per se can be damaged. That is one type. So when that nerve as such is damaged, you have, as I said, multiple increased firing, not only the nerves, surrounding structures. Sometimes if it is, you can have sensory nerve, you can have impact on the sympathetic system. See, they may have injury to a sensory nerve, but they may have sympathetic features also. They may have edema, or they may have sweating, color changes. These are all, if you are aware of CRPS, that they may have injury at one time. But after 3 months, 6 months also, the injury, everything would have healed. But still they may be having some symptoms. Why is that happening? Because even though the injury was to one particular nerve, the surrounding sympathetic system, they may have shiny, if for example, if it's in the periphery limbs or something, the whole limb can become swollen, can become reddish, can have different, if they have injury in the right foot may be either hot or cold compared to the left one. So those are all sympathetic symptoms. So like that, it could have just from the nerve or the surrounding structures, mainly due to increased response. And next thing, what I generally try to explain is, if, for example, if someone has surgery, they may not have an exact injury to the nerve, but when someone is doing surgery, all of you or most of you being nursing team, see, the nerve per se need not be cut, but when they're doing surgery, they'll be moving the structures so that, for example, they're dealing with the bone. They will move the structures so that they are able to access the bone. So the nerve may not be cut, but it will be sheared, I'll say. It will be pushed here and there. So even that sometimes may respond. The nerve, how it will respond because of the plasticity, we cannot say. So even though there's no injury, but just this handling of the nerve can have some impact. So that is why this neuropathic pain is very, very important and has to be considered as an element in chronic pain, any type of chronic pain. Okay, and you have to have in mind, this is one of the reasons why when you go into and see about management of pain, the neuropathic pain medications play a very big role. They are called as adjuvants in pain management. So if you understand this, you will know why and how it works, and it is a very, very helpful element to deal with the pain. Okay, next comes allodynia. What is allodynia? Allodynia is pain resulting from a harmless stimulus. See, normally this stimulus will not cause pain at all. Examples for allodynia will be some patients, when they have chronic pain, they will feel pain to touch. See, normally none of us have pain to touch. Otherwise, we won't be shaking our hands or tapping our back, or all what we do, hug and things, all that, because we don't have pain to touch, we do that. Whereas in patients having chronic pain, pain to touch. Another common symptom, what they say is, even their own dress, like a skirt or sari or something, when it touches that part, oh, I have so much pain when it touches there, I can't bear with that. So those are all called as allodynia. Next one is hyperalgesia. Small exaggerated response to a normal stimulus. For example, this stimulus, small hit, should have certain response, but they will have exaggerated response. That is hyperalgesia. Last is referred pain. Pain felt in an area other than the site of origin. For this common example, what we give is heart myocardial infarction or chest pain or heart attack. See, they should have pain only in the heart or this side of heart, but they may have pain in the left arm. They may have pain in the neck. They are also symptoms of myocardial infarction. So that is called as referred pain. That is pain which is not at the site alone or where the cause of the pain is. The pain could be in another place, but there will be a nervous connection to that. That is why this type of referred pain happens. Okay, now we come to the assessment of pain. Proper assessment of pain is essential, and it also has to be reassessed regularly. Here, two factors have to be considered. Why is it mentioned that it has to be assessed and reassessed? There is significance. First, to know whether the pain is changing. First time you see, that is why every time we see a patient, we have to ask. How always when we are asking, it has to be an open-ended question. Is there pain? Yes, no type of answer we don't want. So we should frame the question in such a way. How are you feeling? How is your pain now? So if you give an open-ended question, they'll say, no, my pain has increased. It has increased from one place to another. It is now there all the time. So we have to give open-ended questions and assess it every time we see them. One is to know how it is. Next is if you're given some medication. The next answer from that point of view, I started taking the medications. So from that time, my pain is not as bad as it was before. So something like that. So that is why assessment and reassessment is very, very essential. And next, nursing team has an essential role in this, as patients are seen regularly and at times more often by them. See, you may be going to the field and seeing the patients more. The patients may be coming to see the doctor once in 3 months or something like that. Maybe you may go see them more often. So that is why you have a big role, and that has to be understood and implemented. So see, if our profession has a very important thing, that self-satisfaction that you get when you see a patient cannot be matched by anything else. And as you have a big role, if you understand and do it properly, the benefit is for the patient and satisfaction is for you. Hence, this has to be understood appropriately and adequately and utilized. Okay, coming to describing pain. What are the factors which we have to consider? We have to see where the site of pain, the nature of pain, whether it is throbbing, pricking, what type, extent, from where to where, it's there in one place, no, it's there, the whole area, something like that. Then next, aggravating and relieving factors. What makes the pain worse? What is that relieves your pain? All these factors we have to ask to know the type, nature, everything. And whether this pain is impinging on your routine activities. Some people may say, no, because of this pain, I literally can't do anything. And sometimes they say, no, it's impinging on my sleep. I have not slept for many, many days. So all these factors are important. Next comes the assessment tools. There are plenty of assessment tools. Regarding assessment tools, one important thing what I generally say is we would generally mention what are the basic or standard assessment tools. But each center will tailor make specific assessment tools to cater your demands and needs. So I would just give a basic one, but each center will be following something fine. Anything, all what is said has to be covered. So always it is said, see, you have to do it according to the regional need, language, and then what demographic type of patients you're seeing. All that has to be considered when you have assessment tools. So we will see a rough guide. And for acute pain, normally we have the numerical rating scale. I will show you pictures of them also. So basically you have the numerical rating scale, visual analog scale, verbal rating scale. And then also you can have in mind a dynamic pain assessment. Basically, like see, sometimes I don't have pain when I'm sitting or not doing anything. Once I get up and walk, I can't do anything. So what does that mean? So any movement causes or aggravates it. See, from this point of view, one important thing to be considered is dynamic pain will be there, but if they don't move at all, the pain will only get worse. So that also has to be conveyed, but assessment has to be done to what extent it is. And then see, these are for, even though it's mentioned acute pain, chronic pain separately, but they are all interrelated, okay? We will use all these things together. Mainly when you go into chronic pain, you have to have other factors also. We have seen chronic pain has so many elements in it. So that is why you have the other main things what I've mentioned here, and the brief pain inventory, where each element we saw, site, nature, all that will be expanded. Each one, or if you, for example, you take one factor in that, whether it is mild, moderate, severe, and what, for each one, we will go into more detail. And then you have the Megal pain questionnaire. There also a expression, oh, this affects my sleep, and it affects my activities, and it affects my mood. So in these things, these chronic pain tools, you have an in-depth assessment of each factor. Because see, whenever you have chronic pain, you have to assess the patient's mood, whether the patient is feeling sad or happy, whether the sadness lasts longer. And with that, we can even guide whether they are depressed. So all those factors are incorporated in these additional tools. And on top of that, you have some disease-specific and multidimensional questionnaires also. For example, diabetic patients, you need to have more. Someone may have dementia. So that is why it is a vast collection we have nowadays, but we will use according to what we need. So for example, we'll see, for cancer patients, we have to have something different. So everything has to be borne in mind. So dementia, someone living in some nursing home, they will each one, like disease per se, diabetes, arthritis, so everything has some salient feature. Why I'm telling more about diabetes, it's a common thing. So for example, if you check diabetes, if their diabetic control is not very good, their pain will be worse. So there, for if you're seeing such type of patient, we have to first see, are they having proper control? Is their HB1AC okay? So all these factors also have to be incorporated. So they have not been seeing a diabetologist at all for some time. So whatever effort you take, if that is not corrected, the benefit is not going to be good. So all that has to be borne in mind. So coming to the standard things which I will show, which are helpful, and you can see and use what is available in your individual practices. See this depiction, this chart, because see, even if someone can't speak the language or something, by pictures. So this has a picture of the front and back. So if you tell them to mark in this where they have the pain, so they can mark here, they can mark many, because in chronic pain, if you take, they may say 10 places. So they can mark all this where all they have their pain, from where to where it is there. So in that point of view, it will be helpful to have some chart like this. So for them to give for us and them to understand clearly where and where is the area of pain. Next, see, as I said, this visual, verbal rating, numerical rating scales. We have generally this green is no pain and red is in being in agony. So under that itself, you have the and number. Normally, if we tell our patients if 0 is no pain and 10 is maximum pain, where would you say? And say from what God's grace, I've had the benefit of practicing both in India and here. So patients are very, even see, for example, in Adyar where I've been, I've seen patients from Assam to Trivandrum type of thing. Language is is good if you know the language. Not that if you don't know the language, nothing can happen, no. Sometimes I've been fortunate to speak few languages, but even without that, with these pictures, you can manage. If I know to speak, maybe the patient may not know anything, but still you can convey and get the information. So with the pictures, with see either picture, number, or explanation, or is it mild, or is it very bad, or is it tolerable? So see, all these you can use. So again here, assessing, reassessing. First time when they came, they told me, oh, my pain is, they scored it to 8 or 9. Okay. We gave some medicine, we gave them some techniques, taught them some things, all that we did, how to manage their mood, how to manage their stress. So then next time when they come from 9, oh, now it's only 4. So from management point of view also, no, next time it could be the other way around also. No, doctor, I had an episode of some extra flare-up of symptoms. So it went to 6 or 8. It came down to 4, it went to 6, and now it's settling down between 4. So it gives us an idea both about their disease per se and management also. So that is why assessment, reassessment is very, very essential. And see, in one thing, and in many studies they have done and seen this numerical rating scale, 70 to 80 or 90%, it coincides well, it seems. They have done studies internationally and found that this verbal and numerical rating scales are appropriate. Okay, coming to cancer pain. The major impact of cancer pain assessment and management happened after the WHO guidance of 1986, but still satisfactory level of management is not achieved in many parts of the world, developing many parts of the world. They say still not satisfactorily achieved because of the easy non-availability of analgesics. And they're trying their level best to make sure that it reaches all parts of the world. In the assessment tool for cancer pain patients, it is just not the pain. All things that I mentioned here, for example, activity, nausea, depression, anxiety, which, see, anxiety is an important factor in cancer patients. So that has to be given important. And so we have to spend time and explain to them, see, it is inevitable state. But even though it is like that, what can I do to have for you to have a better quality of life? And then appetite is another important factor. They will have loss of appetite. So we have to tell them loss of appetite is a symptom and the disease per se causes it. It's not that. Here, training and giving awareness to the family is more important. We have to tell them, don't force the patient to eat because they can't eat. You give them small quantity, half a glass every 2 hours, rather than giving 2 glasses. You have to drink, force them, and they will have difference of opinions between the time. The family wants to look after, patient is already in agony. So every factor, if you sort all this awareness, the pain itself will come down. So everything, so pain, activity, nausea, depression, anxiety, drowsiness, appetite, well-being, shortness of breath, everything has a role. So hence in cancer pain, we have to go into a broader picture and look into everything to get better benefit. Okay, last but not the least, why have I got these pictures of birds and nature? Okay, a thing of beauty is a joy forever. So always, and nature is a gift of God. It's beautiful in all forms. No one can deny that. So, and why have I mentioned this? See, we have seen now in this 30-40 minutes, pain as such, it's got a physiological element. It has got a psychological, social, emotional element also in it. So what can be changed should be tried to change. What cannot be changed, we cannot change. So the social, psychological, emotional element, you try to put something nice and happy. Nature, why it's it. So anything from nature that you get, that happiness lasts longer. So that is why. So if we try, okay, we'll try all efforts to manage the pain, but also give them some nice experiences and ways and means of managing it nicely. So collectively, we will be able to get a better response. So that's how I would like to end. So we should collectively try to see and modify and teach them and give them awareness about, oh, it's not that you're having all these symptoms. It is true, but we will see how we can manage it to reduce it and to give a better quality of life. Okay, thank you very much. I will stop sharing and then.
Thank you, ma'am, for the excellent session. Anybody have any
Welcome.
doubts? If you have any doubts, please unmute yourself and talk, or you can put your questions
In
in
the
the
chat
chat.
or whatever they want
Yeah.
to do.
Any questions?
बोल के बोलने क्या हो गया माइक ऑन कर नहीं बोलना
Okay, nociception is actually it's a process of recognition of any see, like heat. If your finger touches heat, can't they hear me well? Someone has mentioned.
We can hear you, ma'am.
Because someone had mentioned in the chat, volume not clear.
Maybe.
Can you hear me clearly now?
Yes, we can hear you.
Okay. So, okay, basically nociception means, like for example, heat is a common example given. So when your finger touches heat, that process by which the heat sensation is felt from the finger to the brain and come, that process of identifying or recognizing that abnormal stimulus is nociception. Is that clear? Or if you want anything more, let me.
Any other questions?
That's all. See, one thing is, the main thing with pain is it is generally felt co-injury. It is just not that simple. So that is why, like if you share these slides with them, and if they read and go through that itself will help them, so that they get an idea on, because enough and more information is there. But this much has to be given. I reduced as much as possible, because without knowing all this, it may not be sufficient. So if they read through this slowly and go through, and as they see patients, so now once with all this information, then you go see patients, it will make more sense. Oh, that is why all these things are there. It's just not one point of injury alone. So many amplification, all this you generally wouldn't have thought of. We say pain and things, even in the general medical curriculum itself, pain pathways there. This modulation and things are not kept or dealt so much. So slowly they are incorporating all these things. So that is why it is a bit of extensive subject. So once you see patients and combine both, link both together, it will be helpful.
Thank you, ma'am. Any more questions? So we all nurses, we are spending more time with the patients. I'm sure you have a lot of doubts regarding pain. If you have any doubts, please ask Madam. And also we have learned many things today. We need to understand that pain is a subjective experience. We need to believe the patient words. So pain and the definition is pain is what the patient says hurts. So if the patient is complaining of pain, you have to believe the patient words. So coming to the assessment part, also Madam was saying the different types of pain. We have to understand the types of pains. Based on the types of pain, we need to treat the patient's pain. So if the patient is having nociceptive pain, we have to give that kind of medication. If the patient is having neuropathic pain, you have to treat their neuropathic pain. So Madam was saying that the role of adjuvants. If the patient is having a neuropathic pain, we have to add a tricyclic antidepressants like amitriptyline or imipramine, like that. So that is very, very important. During the assessment, you have to do the proper assessment. What type of pain? So what is the severity? So what we do here is the assessment stage, we do STPQ, things. So S is site, D is duration of pain, P is provocating factor or palliative factors, Q is quality of pain, and R is radiation of pain. S is severity. Severity is, Madam already said that the severity of pain, we can assess 0 to 10 scale. So you have to ask the patients about their own pain, so they can able to score their own pain. So 0 means there is no pain. 10 is worst imaginable pain. Then you can ask them what is the current pain, the severity of pain. Then they will tell you 8 out of 10 or 7 out of 10. This based on that you can treat the patient. And the T is temporal factors. This way we here we doing the assessment. We are doing the assessment. So you can do the proper assessment. That is very, very important. And once again, I want to tell you all, we have to believe the patient words because this is the subjective experience. So the patient, they only know what that kind of pain they have and what is the severity of pain they have. So sometimes they are not able to express their pain, but they can able to tell you, so I am having severe pain, like that. We have to believe the patient words. Okay, so
Just a minute. Someone has asked about allodynia.
yes.
See, allodynia is the examples that I gave are the common examples. So normally they should not have pain for this stimulus. So the examples that I gave is touch. So normally if someone touches your hand, you should not have pain. So what happens, for example, this allodynia could be near or at the site of injury. So they may say, no, I had fall here. So not only at the site, it could be a generalized. If you touch, they'll say, no, that hurts. Normally, touch doesn't hurt. And that is why the common examples that I gave is, if by chance their own dress touches, they say, if my dress itself touches my knee, it triggers the pain. So it could be in any place. So any structure, it could be your dress. Or for example, if someone is walking and they go past something, just a touch of it, if you hit, you will have pain. If you bang your leg on something, you can have pain. But just by going near something, if you have pain, that is an example. So normally we say pain to touch and pain to your garments or something touching the parts of the body. Those are the common examples given. And as you see patients, they also will say, no, I myself can't touch my left hand with my right hand. So that's what, like normally this cervical pain, And in cancer patients, what they say is the disease per se can have spread to nearby nerves and give pain. Or it says it can have a neural component of it, and the chronic nature of the disease can trigger neuropathic element. So that is why, as she mentioned, whenever we see patients, initially we may give painkillers, okay, according to the WHO ladder. But here, adjuncts do have a very big role, because already they'll be in, for example, they are in some severe stage of the disease. Other organ functioning, everything is not okay. So then we have to be very careful when we are giving the medication. So at that point, when you cannot keep on increasing your dose of your morphine or something like that, the adjuvants, the neural element, for example, gabapentin or pregabalin, has a very, very significant role. You can maintain the morphine at that level, but if you start the gabapentin or pregabalin, they will have good response. They will be able to sleep, because the positive elements from that also are there. So collectively, this neural element, when you manage, also will be helpful. And one more thing, as you were mentioning, when you're seeing the patient and you say you have to believe, yes, we have to believe, we have to accept, tell them, yes, it is true. And we also have to help to guide them to reduce. We know that, yes, you experience difficulty all fine, but by just being experience the difficulty, is that helping you? Do you want to know something to overcome that and become pain-free? That point, they'll say, yes, I didn't know that there's an option. So that is the time we have to utilize. See, when we see patients, we have to grab the right opportunity. Okay, they will be upset, they are subjective, all that is there. But when they're coming to you, they say, okay, you have been struggling like this. Do you want to get rid of this and become all right and have a better life? Oh, is there an opportunity? Yes, you utilize the opportunity. Teach them some measures to overcome all this, like breathing techniques. There are so many things nowadays. So there you utilize the social, emotional element in it. Even for cancer patients, when they cannot move, there is something called as chair exercise. You just sit and stand, need not do anything more. So like that, there are so many ways and means of improving their quality of life. I can't do anything more. You need not do. I understand you are in such a frail situation. How on earth you will do? You can't go run. But you have to tell them what are things. Just get up, sit and stand in your chair before eating. Do 5 steps to go to your to get your food. Something like that. You have to give them simple, measurable, doable acts. So here we have to use and utilize stuff to help them to have better quality of life. That is what is essential. Okay, any other query is there? Let me have a look at the chart.
Yes, one more question there, ma'am. So what is the difference between allodynia and hyperalgesia?
Allodynia is for a non-painful stimulus. Hyperalgesia is for a painful stimulus, exaggerated response. For example, someone pricks or see, that is the big difference. Allodynia, non-painful stimulus, pain. Hyperalgesia, painful stimulus, for small pain, big pain is perceived. That is the difference. And there was also one more question, dear. Shingles, would that be? No, shingles is not allodynia. Shingles is a disease per se. But in shingles, what happens is you get post-herpetic neuralgia. There, the shingles element becomes a chronic neuropathic pain. Why and how shingles happens? That's why I see everything, knowing the cause and pathophysiology is important. Shingles, basically, they would have had chickenpox in childhood. In the spinal column, dorsal horn, you have those organisms there. They get re-triggered, and that is how you get shingles. That is the pathophysiology for shingles. So there, the neural element is there in shingles. So the shingles as such, here again, extra firing, all that what I said about wind up and central sensitization is the reason. So in shingles, what you get is post-herpetic neuralgia. That is what the shingles comes and goes, but the pain persists. There, the chronic pain is triggered. So you have something called as a post-herpetic neuralgia is what happens. And there, gabapentin is one of the very well-known medication found to be useful. Elderly, normally the shingles happens more if someone crosses their age of 60, 70 and all, very common. And small dose, you can try small dose gabapentin. They may need it for like 3 months, 6 months, or some people may need it for a year. And then you don't worry, you will be able to stop. And by 2 years, maximum 2 years, it will completely go away and they can stop medication. We have seen many patients like that, and it is useful. So that is not allodynia, that is chronic pain. So see, again, you can't say 100% it's not allodynia. See, the shingles would have come in, for example, they may have in the back or something. It will go, but the allodynia, what happens there is the chronic pain element which has triggered. So allodynia is a neuropathic symptom. So you can't say it as not, but if you understand the pathophysiology, it is a chronic pain, chronic neuropathic element which stays. And there it will be one of the symptom of chronic neuropathic pain. So sorry, I won't be, sorry to say that you can't say it's not allodynia. Allodynia will be a symptom of the chronic neuropathic pain. Is that clear? Who was that who asked it?
Yes.
Let me see. Salome. Is that? Have I got it right?
Yes, Salome.
Salome, I wouldn't say that, you're right. It is a symptom. It is a symptom of chronic neuropathic pain. There, the neuropathic element is the chicken pox staying in the dorsal horn, and that's how chicken pox. Then only if someone has had chicken pox, that virus stays there. And that gets triggered after many, many years and becomes a shingles event. Okay, hope it's clear.
Ma'am, one more question. Vishaga said, could you please explain pathophysiology once again?
No problem. See, the basic pathophysiology is like, see, pain is a complex phenomenon. Okay, it is not a simple, straightforward. Like you have site of pain, and you have the it goes through the ascending pathway, brain comes. Why? Because it's not a hardwired system. What is a hardwired system? Hardwired system means it takes only one path. And if it starts here, it will take one route, come back. No, it is not like that. That is why it takes the from the site through all these chemical mediators and goes up to the brain and comes back through descending pathway and things. And it has something called as peripheral and central sensitization. This peripheral sensitization is at the site of injury. Normally chemical mediators are released. That chemical mediator release itself, it's a small amount, but that can become more. It can have extra triggers, and not only one side. The surrounding structures can also be triggered or activated by this inflammatory soup. What is inflammatory soup? It is the cytokines and prostaglandins. See, inside our system, all actions take place because of the chemical substance inside. For example, heartbeat, all that, how it happens, the sodium, potassium, how much sodium is there, how much potassium is there, what is inside, what is outside, everything triggers. So to the naked eye, we cannot see all that, but everything has a role. So like that, you have some sensitization, means it is becoming more triggered, or it is hyper excited. that type of thing happens in the periphery, that is near the skin or structure. And the same type of sensitization happens in the central nervous system also. Central nervous system, okay, one stimulus comes, one response. No, no, no. What is wind up? One stimulus comes, I'm going to give 5 response. That is amplification. So that amplification can be short-lived. No, my brain makes up a different idea today. No, no, I'm going to have this 1 for 5 years. So these are all, that is what is plasticity. See, the human central nervous system, so many things still not understood very well. Nothing wrong in accepting that is reality, okay? And next important thing is, in today's world, they have done something called as focal MRIs, fMRIs. That is, they see the blood flow in the brain for a person who has chronic pain. So they say this what I'm telling, this hyperexcitation, wind up and all is just not spoken. They have proven with MRI studies. And so they show this excitation. So this excitation is in the periphery, is in the central nervous system, called as wind up. So that is why. So this is the pathophysiology. It is not simple. So, and all these things are there, which make the pain not a simple one. It has so many components. And on top of this, you have the psychological, social. Even for that psychological, there is evidence that how, when you feel low in mood, what chemical mediators are released, and then the pain. That also there is a very good interaction, and similar things happen at the same time. So all these have been mentioned. So these are the main pathophysiology to understand. So as these components are there, that is why we have so many factors in it. Hope it's clear there. If you read once again, see, like sharing my slides would be, that is why I've kept it simple. And on top of that, see, always when you study, the teacher will give you some information, okay? Then the 2 students together should sit and discuss. 4 brains will know different things. And then you have to go to library and read little bit, okay? And then the 4th component, life experience, seeing patients, studying, seeing more patients, you will be expert. So use all these 4 components in anything you do, you will be a master of it.
Okay, that is very true.
No, these are things, see, no one is expert. See, all of us went from first standard to whatever we are. We were not what we were in our first standard, but we came up there because all what I said you would have done. Sit and see, you would have done it. This is standard recipe for study.
Okay. Okay, thank you. So can we move on to the patient story, ma'am?
Yes.
Yeah.
I hope they are all happy with the explanations given.
Yes.
Yes,
Ma'am.
Go ahead.
Okay. Sheba, are you there? So
Yes,
to
ma'am.
you. Yeah, over to you.
Good evening to everyone. Today I'm going to present my case presentation. My name is Shiva. I'm a staff nurse, Emmanuel Hospital Association. So my patient age is 40 years, gender female, and diagnosis is stomach cancer in 3rd stage. So her presenting complaints are insomnia, loss of appetite, and constipation. So history of illness is like this. She had history of abdominal pain. Pain score was 6/10. According to what they are using in their hospitals, like face rating scales. And the pain is associated with burning and thrombing pain. On and off since 6 months, associated with the backache, and it worsened in last 3 months. She got admitted one of the private hospital and discharged with the chemotherapy. Her bowel pattern was disturbed and disturbed sleep pattern. On examination, she was conscious, vitals are in normal range, temperature 98.2, pulse rate is 86 beat per minute, respiration is 24 beat per minute, and blood pressure is 100 by 70 mm of Hg. System in eyes, sclera is white in color. On abdominal examination, mild tenderness is seen in left hypochondrium region, and other system is nil. Treatment and investigation, her HB was 7.8 gram real. It shows anemia, and total leukocytes count is 37,000. Platelets is 1,20,000. Electrolyte sodium is 150 milliequivalent. Potassium is 3.79. Chloride is 111.9. Blood pH is 7.4. And her creatinine was 0.72, which is normal. So we next coming to the psychosocial aspects. 40 years old, married woman living with her husband and with 2 children. Her mother and father-in-law also living together. She was a housewife and her husband is a shopkeeper and he was the breadwinner of the family. Sometimes she will get financial support from her siblings, and she belongs to a Christian family, and she has good faith in Christ but unable to attend fellowship. Her husband has some land for agriculture, but he sold for her treatment. She used to cry and say there is no hope for her living. Medication, tab paracetamol 650 mg Q6H, tab pantoprazole DSR 40 mg BD, tab aceclofenic SR 100 mg PRN, syrup mucin gel 10 ml before food, syrup cremafin 10 ml HS. Her main concern was severe abdominal pain, pain score was 6 by 10, anemia, disturbed sleep, disturbed bowel pattern, emotional unstable, financial problems. Summary, 40 years old woman with stage 3 stomach cancer on chemotherapy and pain score was 6 by 10. So today's discussion points are how we can give palliative care to this patient. Second one is there any other things to do for her to reduce her pain? What are the problems faced by her family? And how we can support and enhance their quality of life? Thank you.
Thank you, Shiba, for the presentation. Anybody have any more clarification there? Anybody need any more clarification? You can ask her. So otherwise, we can move on to the discussion points. Anybody need any clarification? So Shiba, I would like to know about her medications, current medications.
Actually, she's not coming regularly for follow-up, and they means last year only she died because of this problem, because of the cancer on 3rd stage. And current medication, she was on chemotherapy, and this only paracetamol she got from the hospital.
Madam, over to you.
My first query was, why only paracetamol for a stage 3, or was that no other analgesics available there?
Actually, ma'am, I'm telling my sister's story only because she had a stomach cancer and she got admitted in CMC Vellore and she got treatment. Whenever she's getting chemotherapy, she's admitting there and she's getting chemotherapy there itself. But for the pain management only, she got this paracetamol, sumo, and for that she had her port, and in that this collection this on that clotting was formed, blood clotting was formed. Because of that complications, she died.
First thing, dear, deep condolences. See, such as personal thing. You have been a brave girl to come up with this. All our deep, heartfelt blessings for you. Thing is that what came to my mind, you're not, your sister or what you have presented is not something out of the blue. This is what happens.
Yeah.
Okay. So I'm one way glad that you brought this up, because we all say and tell that so much is needed. What Palim India does and what Cancer Institute does and all is like tip of the iceberg. Still, there are so many patients who don't get the appropriate pain relief. See, for her, especially in stage 3. So do you mean CMC Vellore? Near Chennai, few hours from Chennai. Is that place
Yeah,
you're
yeah.
mentioning?
Yes, ma'am.
Oh, okay. Because I am aware. See, having been in Chennai, I've just till 2020 end, I was in Chennai only from 2017. I know that is why I used to take maximum effort. These patients do need some form of morphine. When they are in stage 3, some form of morphine, and that is why, see, in your presentation, respiratory rate 24, that is not normal.
Yeah, because when she was got admitted at that time, she hasn't had pain, ma'am, but with some complications, she developed all these symptoms.
And next thing, no, from many patients with so many other factors in mind, even they won't express their pain. Only if you ask them, they will say, because they'll say, oh, if I tell this, that will cost me. So for them, pain relief will not be in their mind. So many things, like if you go in an order, what all came to my mind was, from your symptoms itself, not necessary she has to express pain. Many factors were showing that respiratory rate is one of the things which was
Yeah.
high. And
Yeah.
also her hemoglobin being so low, that low hemoglobin, see, it need not be 12 or 15, but 7 with her general activity. If she was the person doing everything at home, even day-to-day activities, she would have found it very difficult. She would have been breathless for doing daily chores.
Actually, she was a very strong woman, ma'am. Sorry for disturbing.
Go ahead.
She was a very strong woman, and she's never expressed her feeling also. So by the time we found it, it's become very late. So this is
So
the
that's
reason.
what. So basically, like a few things is looking into all factors, giving her appropriate pain relief, so she could have had better quality of life. See, morphine nowadays is available in many places. For example, in Chennai and all, there are many places which have morphine, and we give it for like 1 month. And it is not expensive also. Once you get to the right place, and if it is for palliative care, for her, from ideally, see, always I try to say, even though I did not get it, I will try by God's grace, make sure somebody else at least gets it. So from now on, what we have to see, okay, it was unfortunate that she couldn't get the best, but at least we can guide them, identify places where morphine is available, and so that they get it. Even with low dose morphine, they will be fine. Not necessary they all need big doses, because they are all small made, and they are all opioid naive people. So some amount of correct analgesics, some amount of adjuvants, and then proper palliative care will be teaching her the basic stuff, as I was telling through our talk today. What is teaching the patient and the family about what it is, giving them awareness. This is how the disease per se causes frailty. Disease per se causes loss of appetite. They can't do, they are frail. We have to go do things with them so that they give. And financial assistance, you have to get some connection with local organizations which are willing to do help. And then we may not be able to solve everything out, but we can try to solve what is possible, and then should not give any financial burden to them. Say, teach them that if it is stage 3 or stage 4, what it is, what can be done, what can be covered, and what are the organizations which could help them for chemotherapy. There are some places which they give chemotherapy at reduced cost. Only thing, there should be a good collaboration within the teams, because in many places there are identifying. See, demand supply will never match because the demand is very, very high. The supply is not there to meet the demand. But at least if we can see what best can be done, those are the ways and means of managing it. Is there no oncology in CMC Vellore?
Is there, ma'am. She was treated with one consultant, like a private consultant, but morphine was not given to her, ma'am.
No, in CMC Vellore as such.
There is the oncology department, ma'am.
Maybe there's no palliative care there.
No, CMC, there is a good palliative care department.
Yes. Remember, correct. I met one lady from CMC in the Tata conference. Yes. Thank you for reminding there.
Dr. Reena is there. Dr. Reena.
Yes. Now, as soon as you said, it came to mind, because I had been for the palliative care conference in 2020 in Mumbai, and that is where I met many of the palliative care team. Yes. See, that is what. See, unfortunately, I can use the word unfortunate only because I too feel really, really sad and sorry. They don't need hi-fi stuff. They just need some time and resource to tell them what it is. And morphine is not expensive at all. I always think of Dr. Rajagopal only. So the thing, something simple, and God's grace, if you get to know the right thing, nowadays it is available. It's always here we say a standard statement. The patient has to be at the right place at the right time. That is very, very essential. So if they get to that spot and then getting starting at 5 or 10 milligram morphine, many patients I've seen, they'll be very happy with 5 or 10 milligram dose 4th hourly. And then they themselves will, after about 2-3 months, they'll say, no, if I take 4 times, I am okay. They will, I have seen. And then just adding little bit of gabapentin or pregabalin, 1 night dose, that's enough. They have better quality of life. Unfortunately, that's what is the state. We'll hope for the best. Things are improving, and more training and things, we will get there. The whole world is waking up to palliative care, and hopefully we will all get there one day.
Thank you, ma'am. Anybody want to comment on this? Any suggestions?
So is Sheba working in any palliative care at present, or what is her?
No, ma'am, I'm not working in the palliative care. I'm working in one of the EHA, Emmanuel Hospital Association. There is the one organization under that. In a remote area, there is the one hospital. Hospital name is Prem Jyoti Community Hospital. So there I am working, ma'am.
So you are working in a private setup?
Yeah, private.
Where exactly?
It is in Jharkhand, ma'am. Jharkhand.
Jharkhand.
Sahibganj district.
Oh, so from Jharkhand, your sister was living in Vellore, or?
No, we went for her treatment, ma'am.
Yes. As I said, in Adyar Institute, I've seen patients from Assam to Trivandrum. So it was a blessing for me to have had the opportunity to have worked there.
Thank you.
So that's also, we used to see easily, I would see 30 to 40 patients every day. So that's what always, it's a two-way thing to take it like that. So things are improving, but we have to hope for the best. That's all. Availability and things are, as I say, is still an issue in many parts. Thank you very much, dear, for bringing this up.
Okay, so as ma'am said, so I'm so sorry to hear your patient story today. We need to discuss because if another person's like this, that patient should get palliative care along with the curative treatment. So last week we learned about palliative care. So then we learned we have to start palliative care along with the curative treatment. From the point of diagnosis, we can give palliative care or we can give supportive care, so that way we can able to improve the quality of life of the patient and their family too. And another thing is, the next question is there any other things to do for her to reduce her pain? Sure, we can do many things. Now we need to understand that what is the total pain. She has a physical pain, she has a psychological pain, she has a social pain, and she has spiritual pain. So we need to understand that what is total pain. So we should address the four aspects of pain. If there is a psychosocial problem there, definitely the severity of pain will be increasing. So we need to, if there is a psychosocial issues there, we need to do the proper assessment, try to resolve solve their psychosocial issues as much as we can. So that way we can able to reduce their psychosocial spiritual issues, and along with that you can give a physical pain management too. So if the more than this patient is having 6 out of 10 pain, but unfortunately she was getting only paracetamol. That not good. It's not good getting adequate pain relief for that particular patient. Definitely, we need to give a morphine or a weak opioids or strong opioids for these patients. That way, we can able to control her physical pain. And also, the third question was, what are the problems faced by her family? So, four aspects. Definitely, she has faced a lot of problems. We need to give a good psychosocial support to the patient and the family too. So, we need to understand that their loved ones, they are going to lose their loved ones. We need to support the family too. We understand their concerns, the patient's concern, and whatever possible, you have to try to relieve, solve their problems. And the last question is how we can support and enhance their quality of life. So these all way, if you support for the ways, like if you go through the physical aspects, psychosocial aspects, social aspects, and the spiritual aspects, definitely that way they can able to improve the quality of life of the patient and their family. So if anyone wants to comment anything, we can hear. Otherwise, we can wind up the session. Madam, you want to say anything?
No, like, see, you have, as you concised and gave a summary, that's what it is. So basically, that's what, talking to the patient, starting palliative care early and identifying and giving everything, and then giving importance to everything. See, not only the patient, the carer and family have a big role. See, the patient may be in stage 3, stage 4. We have to give best quality and dignity to the patient and give equal dignity and sustenance for the family, because the family is who survive and they have to go through and continue in day-to-day living. Everything, even teaching the family and carer safety. I used to say the carer has to be taught all safety measures, because no point if the carer ends up having some other issue because of looking after the patient, that's not justice to the carer. So everything, equal importance, and being humane, I think, is very, very essential. And financial and things are not going to go anywhere, and we cannot solve everything. We can try to mend and then teach them ways and means, so that they also don't go through any more difficulties. And then collective, that's what nowadays one standard word, multimodal management for everything. Multimodal management only will succeed for anything, any walk of life. That's become the mantra, I think, now. And that will succeed. because we are looking into, like, see, even for patients, what we used to say, see patient as a whole, don't see nose. Or so if the nose hurts, it's the nose belong to the body, or the full patient only hurts. It's just the nose, not the nose. So doing a collective approach is what, and as you've compiled, it's very good. And hope, see, these are all essential things. And as you all collectively take everything together, and if we are blessed to do the best, what we can through our life will be a blessing.
Yes. Thank you, ma'am.
I should thank you also for giving me an opportunity to share with all of you. It's been a big experience and nice thing to do things with you. It's a good opportunity for me. And so I thank once again Pallium, Tipseco, everyone, all in a good, big way.
Thank you, ma'am. Thank you. Okay.
Thank you, one and all.
Thank you, Shiva, for the presentation.
Yeah.
Thank you.
Thank you, ma'am.
Okay.
Thank
see
you,
you
dear.
next.
Thank you very much. Thank you to all.
Thank you all. Thank you, Dr. Radha, for that wonderful presentation. Hoping to have many more sessions with you again. Thank you, Shiba ma'am, for being with us, and thank you, Shiba, for your case presentation. And I have shared the feedback link with you all. Please kindly go through it, fill it up, and let us know what we can do further for you. Your feedback means a lot for us. And I have shared the feedback link in your WhatsApp group also. And kindly, those who haven't changed their name in Zoom, like I can see names like Oppo A5, Oppo A15 in screen. Kindly change your Zoom name into your real name. Otherwise, it will be very difficult for attendance purpose.